Folks, welcome back to the next episode of the Dental Implant Podcast. And I'm excited to have my friend back again with me, Dr. Stavros Eleftheriou. For those of you who remember, Stavros is a qualified max-fax surgeon, and he and I think very, very similarly in terms of biology. We still plan on running our day of biology together. We just need a little bit more time to organize that. So we will be doing that at some point. And Stavros and I, we've known each other for a number of years. We both bang on about biology. And I think, when was it? It was at the Bredent conference last year where, yes, we did separate presentations. And we realized how much alike we actually think.
Yes, very true.
That's kind of like where everything grew from. But I said I've known Stavros for a number of years. Get on very well with him, and he's known as Dr. Bone for a reason, because what he doesn't know about bone grafting is not worth knowing, to be honest. Stavros, please, a little bit more of an introduction to yourself, and then I'm going to start asking you some questions.
Okay, so as you mentioned, I've done my training in MaxFax, and I've been doing bone grafts for almost 30 years now. Well, 29 to be precise. I've tried, I cannot say every material on the market, but every type of material that is out there. And when during my training, the gold standard and the only thing we were using was autogenous bone. And for basic cases, and obviously microvascular flaps with that included bone as well. But in private practice, of course, in implantology, the mainstream autogenous bone graft kind that we use now is the Curie kind of technique, where we harvest bone from the external oblique line. We get a thin layer of the cortex, which is used as a scaffold, and then we use the rest. We crush it or we shave off, the pieces of bone, and we fill in the gaps. That's the mainstream kind of thing that we do with autogenous bone. Back then, that's all I was doing, and then I realized, there are other ways to achieve the same or very comparable result. So I started playing with materials. I decided that the best material I had in my hands back in the day was the allografts, right? Because I use xenografts, mainly bovine xenografts. I've used something synthetics. I was never happy with these biomaterials. The only biomaterial that gave me good results comparable to autogenous under specific circumstances, of course, was allografts. Throughout the years, I've changed my mind and my way of thinking. And I think in terms of biology most of the time, at least I try to. And every case that I do means that I have to put time to plan it the same way we plan implants, right? So when we're talking about implants, we're talking about, let's plan this, let's plan that, the position of the implant, this, that. With grafting, most people don't do that. I would think at least 95% of the people don't think planning when it comes to grafting. Maybe planning their flaps, but that's about it. And I've changed my way of thinking, and now I go based on what I think can give me a solution to the type of defect I have in terms of biomaterial, technique, any other approach that I should avoid or should apply. And throughout the years, the almost 3 decades that I'm doing this job, I've moved away from, as I said, autogenous bone, moved away from allograft, and nowadays, the last 2 or so years, I use something that I never thought I would do in my life. I use xenografts, and I get the same, very comparable results from what I used to get in the past with allografts and autogenous bone.
So we're going to go. I'm going to circle back to this, but for the sake of conversation, I'm going to start to ask some questions, because not all xenografts are the same. And
no doubt,
there are certain ways of processing xenografts which are very damaging. You're effectively not using a xenograft, you're using a ceramic. A lot of these companies, they have very, very, very deep pockets. Therefore, their marketing is
And yeah,
budget exceptional. Okay. The other thing
yes,
that happens as well is people will turn around and say, in my mind, incorrectly, they said, "Well, it's been in use for 30 years. It works." It's like that's the same
yeah.
argument.
The
All
horse and cart has been used for eons, right?
yeah,
Do we use it nowadays?
yeah,
Maybe
exactly correct.
for maybe just for fun,
Yeah,
just to go around the park or whatever, but we don't use it to move around, from home to work and stuff like that because it doesn't work.
exactly correct. And the other thing that I see a lot as well is people say it's preserved the dimensions of the ridge.
Mm.
They are using that as a marker for success.
Of a live reach or of something which is dead.
That's the point. That's the point. So
Right.
we need to change our thinking. We need to change our
Yes.
thinking. So I think, Stavros, probably where we should start is what happens when you use let's call it an anorganic bovine bone. So we're going to talk about anorganic bovine bones. These are the xenografts which have been around for a long time, sintered at a very high material. Okay.
Right.
What
So
happens?
first,
What happens?
let's take a step back and talk about origin, right? Because the origin of a material when it comes to xenografts makes a huge difference. The moment we put something in the body, right, the immune system checks what was implanted in the body. If it likes what it sees or what it feels, the inflammation, the reaction is very minimal, right? If it doesn't like what it sees, there's going to be loads of inflammation. So one thing to keep in mind is that we've been using porcine materials in surgery for a long time. For example, heart valves, porcine heart valves. We don't use bovine, we don't use equine, right? And we use grafting materials for skin and burns and stuff like that come from porcine, right? Most of the stuff that we use to cover the capsules, porcine. We use it in food a lot. Obviously, that's not the same, but what I'm trying to say is that porcine agrees with our body. Bovine, only if it's a steak, right? So if heart surgeons use heart valves from pigs, it tells me something that the heart is probably the most important organ in the body. If it stops, you're done. If you lose a kidney, not a big problem. If part of your liver goes, not a big problem. But the heart, boom, done. So if they're comfortable using that, who am I to say that it's not good? Now, another thing that I'm going to say is that when it comes to porosity, right? Cancellous bone, human cancellous bone, the porosity is about 79.3%. Porcine porosity, cancellous bone, is 78.4%. It's almost the same. If I take cancellous bone from a cow, it's between 12 to 20% less. So you immediately see there's a difference, and the immune system will immediately detect that, the change in the architecture. So origin is very important. Now,
one thing I want to highlight, the word that you said, architecture there, mechanical. So tell us a little bit more about why mechanical architecture is so important.
So we're talking about pores, right? Macroporosity, microporosity. If these are similar to human bone, then the immune system will not react to it. We also need the pores because we have absorption of liquids, of proteins, cells penetrate, the blood penetrates. And if that happens, then you immediately have the cascade of healing happening because you get a clot, you get all the right ingredients in there. If you don't have the porosity, then the material is not integrated into a clot the same way. And you probably have seen cases when you open to go back and to put an implant where you see granules of biomaterial that are encapsulated in small areas bone surrounding them, but that piece has never been turned into bone. There's probably a piece of material that was either, cancellous, cortical bone, or with very little porosity. And the other thing, obviously, is how hard the bone is and how it can tolerate mechanical pressure. For example, many of the synthetic materials cannot tolerate any of that. This is why if you try to use them on a one-wall defect, they'll never work. Because the moment you start having pressure, mechanical pressure on them, they crumble, which doesn't happen with bone, either xenograft or allograft. So there are so many parameters you have to take into account when we choose a material. So origin is one, the porosity, the architecture, the structure of the pores is another. And then obviously the manufacturing process, which makes a huge difference. So what you said earlier, temperature. If the materials are treated at low temperatures, and low temperatures are considered up to 600 Celsius, right? You have very little change in the architecture and the porosity. If you use high temperatures beyond 600, then you have huge changes and they become almost like marble. So they're useless.
It's a ceramic. This is why
Yeah.
go back in 10, 15, 20 years later and you'll still find these particles.
Yeah. And there's a shift from that. I mean, even companies that have been selling bovine bones, a name comes to mind, the biggest name, right? Why did they introduce an allograft in the recent years? Because they've seen that bovine biomaterial is not what they were promising people to be. I mean, I've been doing this job long enough to have cases when that came back, sinuses I had to go back in and there was still material there that was the same as the first day that was placed. I have removed implants with granules still attached to them 8, 12 years later. And it's not a small percentage of that material still inside you. It's a huge percentage. What we want to place an implant in is bone, cortical cancellous bone, or something that will change into bone. I mean, you're doing an autogenous bone on allograft, you get an osteoid, which is lovely. It's organized bone. And then if you do an X-ray, I don't know, a year and a half later, you see that it resembles a natural bone. Most of the xenografts don't do that. I don't want to see something white, a white blob. That's exciting to see at the beginning because you can see more or less how your grafting was, where's the material, but then you don't want to see it when the healing is completed.
Yeah, again, it goes back to what I was saying earlier as well. Some people they measure success by the volume has remained stable, and other people measure success by the white blob that you can see on a radiograph. Neither of those are indicative of true regeneration.
Yes, true.
We are talking about regeneration. We are not talking about augmentation.
Correct. Now, the other thing that we have to take into account when it comes to the volume that you end up having once the healing is completed is that if you're using, for example, an allograft, what you usually end up having, especially if it's cancellous, you get reduction of the volume. And one of the main reason is probably because it turns fast into bone. So by the time you go back in, you lose some of it. I remember as a trainee in MaxFax, back in those days, we used to take pieces of bone and screw them in place, cover them with soft tissue, and we would go back 3, 4, 5 months later, and part of it, or most of it, would disappear. Why? Because it turns fast into bone. So it's not just you put it in there and you're done. There's a few other factors you need to take into account. For example, how much muscular activity you have over the area. In areas where the pocket is relaxed, there's less pressure. You don't have as much resorption. In areas where there's very strong muscles over it, even if the muscles are not moving, they just put pressure on it, then it becomes, you end up with less volume. But generally speaking, the problem we find with volume loss, especially when it comes with allografts or even with autogenous shavings. Some surgeons mix those materials with some xenograft to, find the balance. Now, again, the biomaterial that is treated nicely, and some companies have found the right recipe to deliver good materials that heal nicely, but also keep most of the volume there. And I would go and try and find a material that does that, but also turns into bone in time, right? So something that retains the volume and also turns into bone.
So I want to rewind a little bit because we were talking about the mechanical architecture.
Mm-hmm.
We touched on something, and I feel that we've gone by it too quickly, and we need to revert back to that. And that is the correct porosity,
Mm-hmm.
the correct origin of material allows angiogenesis and cell penetration into the biomaterial.
Mm-hmm.
So what we need to understand, it's not the biomaterial that's doing anything miraculous. The biomaterial is just acting as a scaffold, and what we want is a resorbable scaffold to allow for the body to do what it wants to do. Because we all know without correct angiogenesis, without cell penetration, we do not get healing. Is that correct?
Very, very true. Very true. And the body is what dictates, the immune system is what dictates what's going to happen, right? And when we're talking about bone grafts, obviously the origin is important, the porosity is important. Another thing which is extremely important is that we have to make sure that wherever that biomaterial is inserted, it has to be protected from the soft tissue mobility, from the muscles, from the environment. If we have biomaterial granules that are mobile, then imagine what happens to the newly formed blood vessels. They get disrupted, you get fibrous tissue, and you end up with no healing. It's the same as fractures. So you have two pieces of bone, fractured bone. You have to immobilize those two pieces, and you have to allow the callus to form, and that will become bone. It's exactly the same mechanism. So if those two pieces of bone are moving all the time, you will never get bony healing. And then you will have a fracture that never healed, and there is fibrous tissue between the two fragments. So this is why we create the space, for example, with a membrane or with a Curie plate or with a piece of titanium mesh. We create this protected space for the granules to stay put, for the body to grow, to bring the cells, grow the new blood vessels, and start the healing and give us bone. If that is interrupted, then the result is not going to be good.
Yes, that all makes sense, because we need to start thinking more microscopically. And this is why you and I always say, look, it's the biology that does the work. 100% is the biology that
we just accommodate the biology.
Yeah.
What we do is accommodate the biology to make it happen.
Mm-hmm. And the right amount of inflammation is also important as well.
Yes.
If you have too much inflammation, let me restart. If you have no inflammation, there's no trigger for the body to start the healing cascade.
Correct.
If you have too much inflammation or too much inflammation for an extended period, it alters the healing cascade. This is I think we touched on this last time. This is the whole point of osteoimmunology. So what you need the appropriate amount of inflammation for the appropriate amount of time in order for that healing cascade to continue correctly.
Yeah. So usually the first 4 to 5 days you want to have some inflammation, because the body will bring the right ingredients in the area, will start the healing cascade. If that is extended further down the line and it's more than 5 days, you end up in chronic inflammation with all the problems that brings with it: scarring, possible infection, etc., wound dehiscence and that kind of stuff. So basically the first few days You have the macrophages that function as the cells who clean the area and create the inflammation, etc. And then they switch into a different mode and they help the regeneration. If it doesn't happen, then we end up with a chronic inflammation. And Dr. Joseph Shukrun always says the ideal situation is if you can bring the patients in for a follow-up around day 5 to see what's going on. If there's something which doesn't look good, then you have to intervene somehow to make sure that the chronic inflammation possibility will go away. Now, is it possible? Not every time, because some of us are traveling surgeons, so it's not possible.
Yeah. Okay. So, Stavros, I mean, tell me more about the biology of bone grafting, basically. So, we've already spoken about the architecture, the role of porosity, like an actual mechanic. There's a mechanical role, and the role of temperature. How else should we change our thinking?
It's not just the porosity you have to check when it comes to biomaterial. You also have to think that you need to have a biomaterial that which is hydrophilic. You want a material that the moment you place it into the wound, or the moment you add a few drops of saline or blood or PRF, the material will absorb that immediately. That tells me that biomaterial would absorb the proteins, will come in contact with the cells, and will become a nice clot with the blood, because that's what we want. We want the formation of clot, and that happens within the first 10, 15 minutes. If that biomaterial is not hydrophilic, then it's not going to work well. That's another part of it. The other thing that is important when it comes to biomaterials is how pure and clean the biomaterial is when it's put into the vials or syringes and sent to us. And it's the same concept as the implants. This is why we ended up with the Clean Implant Foundation a few years ago, because some implant companies were, packaging and sterilizing implants with remnants from the manufacturing process, and that would lead to bone loss and eventually implant failure within the first year or two or so. And a lovely looking implant after the first few months would end up in the bin because of that. Because at some point, we put something in the body, the immune system goes and checks all the time. It's not a once-off thing. And if something comes up, then the immune system will react to it. And the same happens with the biomaterials. If the biomaterial is not clean, purified, then again, the body will have a prolonged inflammation, which will not end up well.
So you're saying that the manufacturing process, as with implants, is just as important, if not more important, for biomaterials as well. And it sounds like it's something that's overlooked, because how often do you hear about sterility of, you just presume it comes packaged, it is sterile, but evidently there are other issues, as you said, as you can have with the implants as well. So that's very interesting. That's very interesting. What else, Stavros? What else should we be? How else should we be changing our thinking?
Right. When I'm looking at bone grafting in general, right, the first thing I try to see is to understand the 3-dimensional shape of my defect. And based on that, I decide if I need to create a safe space for my biomaterial to heal. Then once I decide that, for example, if I have a 1-wall defect, it's obvious. If you have a 3-wall defect, it might be a case where the soft tissue, is pushing towards that defect. In some cases, the soft tissue is thick and firm, so you don't have to worry about that. And I look at my defects from all different, sides to understand what is going on. Then I'm thinking about the blood supply in the area. Obviously, in the maxilla, it's always better. In the mandible, a little bit more challenging. But generally speaking, if I compare what we do to what our orthopedic colleagues do, we are very lucky because the blood supply to the head and neck is very, very good. And we can get away with murder on some occasions because of that,
Yes.
right?
Yeah.
So the other thing is that you have to, once you understand your defect, you understand, you know what your options are when it comes to materials in general. You choose the biomaterial that you think is the best for the job. You design the flaps in your mind. You need to think about other things like the suturing material you're going to use. You have to avoid, you know, you have to avoid any suture that is polyfilament. You don't want any bacteria to grow on your sutures. It only leads to inflammation. Then you want to use a biomaterial, if it's resorbable, to be a biomaterial that resorbs with very, very small amount of inflammation. And one of the most popular suturing materials is polyfilament. And when it resorbs with lots of inflammation. And people still use it. And sometimes I don't understand why they do it.
To be honest, Stavros, I think it's they're not taught any better.
Yeah.
It's that simple. You know,
Yeah.
it's for me as well. It is not just, you know, everybody understands, or not everybody understands. Everybody's heard of passive soft tissue closure, right? This is one of the absolute critical keys to grafting.
Yeah.
I think what a lot of people don't get taught is muscle activity. It is okay. It is okay having passive flap closure, but what are the muscles doing underneath when the patient's talking? What are the muscles doing underneath when the patient is chewing, when the patient's in function? Because that muscular movement will also, it's going to cause the same damage. So we need to factor that in when we are planning our grafting as well.
I mean, your suturing, your technique in suturing has to support the biology, has to help you immobilize the flaps. It's not just, oh, I'm closing here, I have released and it's enough. No, because as you say, there's always going to be some degree of mobility. And in some situations, if you don't try to immobilize the soft tissue, then that will lead to inflammation. That will probably lead, in some occasions, into disruption of your suturing, disruption of the healing. So that's another thing to take into account. I always use 2 layers of sutures. I use a horizontal mattress suture, which is placed deep into the tissue. That helps reduce the amount of mobility. And the other thing, which is very simple, but can sometimes damage your healing, is the mouthwash that we use. And there's enough literature to support that. Chlorhexidine or anything that has alcohol in it is the worst thing you can use for healing.
Yeah.
If you're using chlorhexidine because a patient has gum disease or treatment after perio, is fine, not a problem. But if you do a graft or an implant and then patients start rinsing with chlorhexidine, it damages the cells, it reduces the rate of healing, and it's probably one of the worst things you can do. And there's studies that show that it damages fibroblasts. There's studies that show that even in PRF clots, if you use chlorhexidine for a few minutes, it kills, I mean, a huge number of cells within minutes. So the point is to work with the body, to work with the biology, not to, destroy what the body is trying to build.
You know, I'm smiling because I teach that chlorhexidine has no place in surgery.
Period.
There are alternatives which are better. The amount of grief that I get for that is unbelievable. But the evidence is there. The evidence is there.
Yeah. You know? I mean, we've been using salt, right, to preserve food for hundreds and hundreds of years. No problem. We've been using salt water rinses in surgery for decades. No problems. We inject patients. We give them IV. What do we give them?
Saline.
Thank you. We don't give them something with some chlorhexidine in. Right? Why? Because that's not what the cells are happy with.
Yeah.
So anyone who comes and says, chlorhexidine, I always tell them, go back and study better what's going on during healing and what the body needs. Chlorhexidine is great if you have an infection. Okay, maybe it's good for gum disease. But since when do surgeons choose chlorhexidine? I don't know. When I started my training in surgery, we used to use it only with in patients with abscesses, drainage, and that kind of stuff, not for anything else.
Yeah, absolutely. It's we need to start thinking differently about bone grafting. No, sorry, we need to start teaching differently about bone grafting.
Yeah.
Because I personally feel many courses are sponsored by a particular biomaterial, and I'm not saying all biomaterials are bad. I understand there are different philosophies and this, that, and the other. You and I have a similar philosophy. There are going to be people who disagree with us.
It's okay.
And that's fine. Prof Urban, I'm aware that he uses a xenograft that I personally wouldn't use. I'm not saying that I'm better than him. He does cases far beyond what I can dream of doing. Okay, but in my mind, in my perspective, is he's only using that biomaterial to hold a little bit of space. The majority of the work is done by autogenous bone. So actually, it's almost autogenous grafting with a little bit of space maintenance with a xenograft. That's not the same as saying that xenograft works. But what we need to do is we need to start breaking it down, and as I said, understanding what the body wants and what actually happens, as opposed to this looks good on a radiograph and the space being maintained. Those are not indicators of success. We have spoken about, and I would hazard a guess. Please tell those of you who are listening. Please tell me if I'm wrong. But I would hazard a guess the vast majority of those who are listening have never been taught about the importance of porosity and mechanical induction of the angiogenesis pathway. It'll be completely new to a lot of people, but this is the whole reason why I wanted to speak to Stavros, to get people thinking differently. And this is why Stavros and I want to do a day together, because we are only barely scratching the surface. Even a day is not going to be enough, but we're going to give you so much information. It's simple tips and tricks like what we're talking about. Like Stavros is saying, change your suturing with suture material. It will play a massive, massive role. And it's almost, it's like, look, if you do this, you're allowing the body to heal. This is what it comes down to. We need to understand it's okay turning around and saying, I don't like histology. It doesn't interest me. It may not interest you, but you know what? That's how the body works. You could ignore
the body doesn't care.
Yeah, the body doesn't care what you like and what you don't like. I'm not saying you need to understand what each individual cell looks like, but you need to have it clear in your head what the healing cascade is, so you can make smarter decisions. That's what it comes down to. For example, Stavros, right? It's let's just go back to autogenous bone a little bit again, right? It's, people do not realize, or a lot of people are unaware of the fact that if you harvest cortical bone versus cancellous bone, they actually have different uses. So there are more BMPs in cortical bone, but there are more cells in cancellous bone. So what you need to do is you need to understand what you are doing so you harvest the right type of bone to get the result that you want. This is the level that we need to think to. Would you agree with that, Stavros? That we need to, as a general,
no doubt,
we need to elevate what we are teaching and the depth to which we're thinking with regards to it.
So I'm gonna go back to my original training in MaxFax, when we used to do big grafts with autogenous bone, especially in cases where we had big gaps, clefts, and that kind of stuff. The source was always the iliac crest. the hip. And the material that we used to use, I'm not talking about the scaffold, what was, covering the area, because that one, we needed the cortical bone and everything, or a membrane or whatever. But the bone that we were using, we were scooping out cancellous bone from the iliac crest. That was the bone that had most of the live cells that we needed, right? Now, is that always the best? No, it's really good where you need it, because if you just take a piece from the iliac crest and you put it as an onlay graft in the mouth, I guarantee you that in 3 to 4 months, only a small part of that will still be in place. Why? Because yes, it contains lots of cells, but it doesn't contain the bone proteins, the morphogenic proteins, and that kind of stuff. And its architecture is not great for that kind of muscular activity and pressure from the soft tissue and everything. This is why we have moved away from bone from the hip, which was the main thing like 20, 30 years ago. And there are simpler ways, smarter ways to do it nowadays. All you need to do is to understand what the body needs, what you have to avoid, what each area needs. For example, in posterior maxilla, you don't have as much muscular activity as the mandible. So you obviously are a bit more relaxed when you're grafting the posterior maxilla. If you go into the sinus, it's an enclosed cavity. Anything you throw into it, it will somehow heal. Some materials better than others. Now, if you have an onlay graft or a one-wall defect in the anterior mandible, that's a bit more challenging. Why? Muscles, lips, tongue, talking, moving, opening the mouth, all that kind of stuff.
Yeah, we need to change our thinking. And one of my mentors in sinus grafting is Prof. Testori, who's literally written the books on sinus lifting. He's progressed sinus lifting probably more than anybody else. Incredibly knowledgeable, very humble guy, and he's always open to learning. That's what I love about him. But again, this goes back to biology. He understands the biological principles. And when you're doing sinus lifting, it's not a matter of lift as much as you want. You are limited by actually the width of the sinus. So actually,
and the blood supply,
which is related to the blood supply, absolutely. So the wider the sinus,
there's a study that they've used Doppler ultrasound to check what's going on with the blood supply, and they found out that 9 millimeters above the sinus floor, the blood supply start to go. You have less and less and less as you go further up. So if you have, for example, a sinus which has 2 or 3 millimeters of vertical bone, you place plenty of biomaterial to build 20 millimeters. The blood supply up there is not going to be good. This is why sometimes we lose some of the material. And basically, it's a waste of time, effort by material to try and do that.
Yeah, absolutely.
Yeah.
Absolutely. So,
and obviously what you said, if it's too wide, makes it more difficult to get blood supply into the core of your biomaterial. So that's another thing. Yeah.
Yeah. So this is why I always say that, look, we need to elevate our thinking. It's only fair to our patients that we do this.
Yeah.
Right? What we're doing is and I don't mean this to disrespect general dentistry, but a simple occlusal composite is less invasive than the sinus lift. It just is. So
no doubt.
If you're doing invasive surgery, if you're trying to rebuild bone, if you're trying to do sinus lifts, you owe it to your patients and to yourself professionally to do the very best work that you can for them. I will never stop learning, and I know that you're the same. Sometimes you and I send papers to each other saying, "Oh, what do you think of this? What do you think of this?" And I sent you a couple of papers from an orthopedic journal last year, and just off the back of that, it was like, well, maybe if we did this, we'd get a better outcome. And this is how we progress the care for our patients. So Stavros, sorry, go on.
One more thing I wanted to add to that is sometimes people tell me, "Oh, I've been to this course, I've been to this lecture, I've learned nothing." And I always say, there's always something to pick up. Sometimes you say, "Oh, this sounds good and makes sense biologically, and I'm going to try and do that." And On some other occasions, you say, this is all crap, BS. I'm not going to do that because it doesn't make any sense. So there's always something to pick up.
Yeah, absolutely. And I think one of our friends, Howie Gluckman, I think I saw on one of his posts. I think it was only a few weeks ago, and he turned around and said, if I only showed you my top 15% of cases, you'd think that I was an implant god. But he goes, that's disingenuous.
Yeah,
and this is what I like about Howie. I've done a number of his courses, and he shows the most incredible of cases, but he'll show the ones which don't go according to plan as well. And he was like, this is what I learned from when it went wrong, and that's what I love about the guy. So, Stavros,
one of the things we haven't touched upon, and I'm just going to mention it, and then if you want to do any questions, is patient's medical history.
Oh God, that's an entire one in itself. That's an entire one in itself. Yes, I mean, I've seen Shrankovich's paper. Froome, he's got an entire textbook on failures, and I think it's one of these things that we touch on flippantly, and we understand the importance of it, but we're not really taking it seriously. We know the role of vitamin D. We know the role of cholesterol. Prof. Shukrun and Prof. Testori, they release papers on that. We know the role of chronic stress, blood sugar, HbA1c. All of this plays a role. Smoking. Now I now tell my patients, even if they're on 5 a day, I said, you are to stop smoking 8 weeks prior to surgery and 8 weeks after surgery. If you can't do that, I'm not prepared to do your work. And all of this is really, really, really important. So Stavros, as you touched on that briefly, tell us a little bit more about your thoughts, because obviously you're absolutely right. That can be the difference between success and failure.
So anything that leads the body into oxidation can be detrimental towards what we're trying to achieve. What I mean by oxidation, everything that happens in the body leads to some sort of imbalance between the oxidants and the antioxidants. So if there's too much oxidants that are being released, we have to, if you want to get the results, find a way to counterbalance that. If it's very small, the amount of oxidation, the body has some mechanisms. But if we have, for example, a patient who's diabetic, it means that the body is already into oxidation. A patient with lots of visceral fat, same. A patient who takes, antipsychotic medication. A patient who gets stressed a lot, oxidation. A patient who's a smoker. Patient who has had radiation and the blood supply is not great in the area. A patient who doesn't clean well. So all that adds to the oxidation. So a patient walks in, I see the patient the way they are, the body, they're maybe a little bit big like I am, right? If they have some medical problems, if I see that the hygiene is not good, etc., I already have a picture in my mind of what's going on with oxidation, and I'm thinking, okay, this patient probably not a good candidate for a big surgery or something that will last for many hours or needs a lot of steps from my side. Maybe it's best if I can break it into 2 or 3 steps, right?
Yeah.
Or I might say, you know what, this is a patient that I can talk to, explain a few things. Maybe that patient can, change a little bit their lifestyle to improve their situation. For example, exercising a little bit, 30 minutes a day of, fast walk. That will improve things a lot. Change a little bit their oral hygiene, the way they eat. Make sure that there's a balance. In terms of cholesterol, that cholesterol is better controlled. Patient with low vitamin D, we know how detrimental vitamin D deficiency can be. We also know that about 70% of the adult population in the Western Hemisphere is deficient. And when I'm talking about deficiency, I'm not talking about the amount of vitamin D you need to have to be alive, because that's one thing. The vitamin D is one of the most potent antioxidant agents that we can take. And if we don't have a good level of that to counteract the oxidation that the body is into, plus the oxidation that I'm going to push even further with my surgery, then the way the body will react is not going to be good. So the levels we want to have are much higher than the levels that sustain a body into life. And how would I judge if a patient needs supplements when it comes to vitamin D, right? Anyone above a certain age, maybe let's say 40 years old, anyone who lives in the UK doesn't go out in the sun, right? Anyone who has darker skin than, a white person, because that means they produce less. The other thing is that we work indoors, so we don't have any exposure to the sun, right? I mean, all that, basically, as I said, 70% of the other population needs some sort of supplementation. Now, do we know what's going on with with LDL and HDL and glucose, and what's going on with the white cells, the red cells, the platelet? There's some ways we can look into it. Not many, actually. There's only one way: blood tests. How accessible these blood tests are, that's a different story.
That is a different
right?
story.
Yes, especially in the UK. I mean, there are countries in the world, for example, in Greece, in Cyprus, in some other countries, you just walk into a lab and say, you know what, I want you to do a full blood count for me. I want to check this, da-da-da-da-da. They say, okay, how much will it cost? I don't know, £100, £200. Okay, you pay. And then by the next day or in the afternoon or in 2 days' time, you get the results.
Yeah.
No problems. It's possible to do in some countries. In the UK, even if you do need a blood test for whatever, you have to wait to be seen by a GP. The GP has to prescribe them. You have to go to the hospital. Sometimes you never get to see them, or you just get a report that says, yeah, this is normal and that is normal. But normal can be many things. For example, a diabetic patient who's controlled is very different from what we want to make sure that the treatment is going to be as good as it can get.
Yes.
Because for a diabetic nurse, if the HbA1c is like around 7, it's okay. We wouldn't want that. We want it even lower than that. The good thing is that recently a recent new thing that was introduced in the market in the UK. That was a machine that was designed by Dr. Shukrun. It's a chair-side device that allows us to analyze blood within 15 minutes. And you can either use a few drops of blood from a finger prick or a very small amount from, phlebotomy. And it gives you a full blood count, glucose, triglycerides, HDL, LDL, and vitamin D. And the other thing that it does, it calculates the two inflammatory indices, the SII and the SIRI, which are the two indices that we use in surgery. And the last several years, there's a lot of articles being dealing with these inflammatory indices. And these indices show that if the numbers are high beyond the normal range, there's more complications after the surgeries. In cancer cases, you have much lower survival, 5-year survival rates. There's even some studies recently in the last couple of years when it comes to perio patients, implant patients. So these are some of the things that we can incorporate into what we do. And get some chair-side screening of these patients. If we pick up something big, we can refer. If we see something which is basic, we cannot give advice to the patient. So it's not something that every single practice can justify buying because it has a cost. But a clinic that is quite busy with implants and perio is something that can give us a different perspective when it comes to diagnosing patients, because nowadays we've got the CBCT scans that give us a lot of information about the anatomy at very high precision. We do get the patient medical history and everything, but what we're missing is what's going on under the skin.
Yeah, I mean, imagine if you were a clinic where you're doing a lot of big surgeries, you are doing full mouths regularly, and you're not doing these blood tests, and you're going
And you
in blind.
usually have patients of a certain age with medical problems that on medication and stuff like that. So when it comes to surgery, generally speaking, I'm not talking about dentistry now, generally speaking, blood tests, blood work is always comes before surgery, always.
Yeah, would orthopedic surgeons even consider doing surgery without blood tests?
No, of course not.
So, Stavros, collating everything together, which, for those who are interested, which material do you like to use? What for you works in terms of
Yeah. So as I was saying, I started in my training with autogenous bone. I started doing Curie techniques in the early 2000s, right? And then I was trying to find simpler solutions, and I was using allografts for a long time. And then I started, after a recommendation by a friend of mine who's a surgeon in France, I started using a specific porcine biomaterial. And he was telling me that it works like an allograft. And I was saying, yeah, right, blah, 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 blah. No way. And I was looking at his cases, and I was always thinking, really? They look great, but is he really using this porcine biomaterial, or is it just doing it for the sake of, because he's a KOL for this company, etc., etc. And I started mixing my allografts with that material. At the beginning, I was doing like 20 or 30% of this porcine xenograft, and the rest of it was allograft. And I was doing everything with that. And then I decided, let's go 50-50. I was doing 50-50. I would get very comparable, almost the same results, or maybe the same, I don't know. And then I thought to myself, you know what? I've got a socket. Let's try this material on its own in a socket. What can go wrong? If it goes wrong, I'm just going to go back in and do the surgery again with something else. And it worked. I tried it again. It worked. And then I thought, let's try it in a sinus. It worked. Let's try it for a horizontal augmentation. It worked. Let's try it again and see if it was just the once off, or is it something that happens all the time. And it was giving me the same results. And then I started doing vertical augmentations just with this porcine xenograft. And people say, xenograft. No. But again, it comes down to origin, manufacturing process, purification. And obviously, even if you do get all that, you have to apply the right technique for the right area and the right shape of the defect. Otherwise, it's not going to work. So if you have all that and you use the right material, then it's very difficult to go wrong. So if you want the name of this material, what I use, I'll give it to you. It's called Pergo. I've been using it for the last 2 years on its own. Most of the time I mix it with PRF. Sometimes if the patients don't want me to take blood, or if I have the odd patient with very difficult veins, I just use it on its own with some drops of blood I take from the wound. And I get the same consistent, reliable, and repeated results.
Amazing. Stavros, thank you so much for joining me this evening. As always, I always learn something new whenever I'm speaking to you. So, folks, thank you very much for joining in. I'm sure we'll be speaking to Stavros again in the future. If you would like to join us for the Biology of Implant Day, which we haven't got it booked at the moment, we're just trying to generate some interest. Feel free to reach out to myself or Stavros on Instagram, or go to my website, academyofimplantexcellence.com. If you download a brochure, you'll just get added to the mailing list, and as events come up, we can send you that. If you like learning in depth, as what we have been discussing today, this is just scratching the surface of what we teach on the Academy. The Academy is split into 3 modules. You can take one module at a time. You can take them all in one go. You can even study for the diploma. If you wanted an EduQual Level 7 diploma, please head to academyofimplantexcellence.com. You have direct access to me. So although the theory is all taught online, it's not you can't get hold of me. You can ask me as many questions as you want. How fast I can reply to them may be a slightly different answer, but I generally try to respond as quickly as what I possibly can. And the reason is quite simple, is I love teaching because I love implants. You guys know this. I love learning. That will never stop. And Stavros, I think maybe next time we should start talking about PRF. What do you think?
Yeah, why not?
Let's do that next time. Okay.
Okay.
So Stavros, thank you so much for joining me this evening. Folks, if you are interested in the biomaterial that Stavros uses, he mentioned the name Purgo, P-U-R-G-O. And as I said, if you follow him on social media, he's an absolute wealth of knowledge, absolutely lovely guy, good friend of mine. Folks, thank you very much for tuning in, and I'll speak to you soon.